Good evening, everyone, and welcome to the Lifesaving Society Manitoba Branch's Instructor First Aid Update. On behalf of the branch, I'm Chris Love, one of the branch trainers, and this is Kathy Plett, our program coordinator.
Hi, we're here tonight to do the 2016 First Aid and CPR updates. So we have a PowerPoint presentation that will be narrated by Kevin Tardif and Sarah Painter, and we have some volunteers coming in to do some demonstrations of some of the new techniques and skills that you'll be having to teach and evaluate in your courses.
While we're going throughout this evening, we have a hashtag that we would like you to use if you want to send any questions in to us. It's hashtag LifesavingFA update. Okay? Use our Twitter channel at LifesavingMB to send us questions at any time throughout the evening.
And just one final reminder, if you haven't done so, you'll need to sign up and get a ToolKit account to be able to access the quiz and everything else that goes along with this update so you can complete the process.
Okay, good evening, everybody. Hi, Sarah. How are you?
Hi, I'm pretty good, Kev. How are you doing?
Excellent, excellent. Good. You ready? We're going to get going, and everybody's going to see some PowerPoints.
Yeah, we've got some exciting updates for you guys.
Go ahead.
So, the Lifesaving Society is a member of a Canadian Consensus Guidelines Task Force. So, essentially, our group, the Heart and Stroke Foundation, the Canadian Red Cross, and St. John's Ambulance, as well as the Canadian Ski Patrol, come together and looked at the new science and developed some consensus and came up with guidelines that all programs were going to implement for their first aid and CPR updates. So this document, along with the European Resuscitation Council and the International Lifesaving Society, were used to govern these updates.
Yeah, so some of the summaries that we're going to be looking at tonight and we're going to be talking about are things like hands-only CPR, emergency medical services and the use of mobile phones, and effective CPR protocols as well. And we're going to get some demos on some of that as well.
Okay, so starting off with hands-only CPR, this is a newer concept, and what we're really looking for is to encourage more people to get CPR because there were times that rescuers were resistant. So right now, if somebody phones 911 because there is a patient that is unconscious and requires care, dispatchers are going to direct bystanders to do hands-only CPR, which means essentially they're going to provide chest compressions until the ambulance arrives. So trained rescuers are going to provide rescue breaths and compressions when doing CPR the way we've always trained them to do, but this really is relying on barrier devices being present. So what we want you to know is that you will continue to teach CPR with rescue breaths, with barrier devices in the programs, and hands-only CPR is going to apply to the person walking down the street that maybe doesn't have any of those devices, that they can still provide some level of care, and to anticipate that those will be instructions from 911.
Yeah, so basically this is a policy change to promote people doing CPR, a willingness to do CPR. It's not really about one being more effective than the other, right?
Right. It's about really encouraging that something is better than nothing. And so if you're standing there, you may as well provide chest compressions. That's actually going to offer some survival benefit.
Awesome. Okay, so EMS and mobile phones. So this is important because, they're so prolific, and we really haven't even gotten to the tip of the iceberg as far as what cell phones are going to be able to do for us in emergencies in the future. But for now, we've got to be realistic in that most emergencies, we find that mobile phone services are available. In most cases, there's a 911 servicing cell phone system available. So if that's the case, if you have a cell phone at hand, call EMS and put that phone on speaker mode is the best thing to do. I even find if you have to provide care, first aid care or CPR, tell the operator that's you're the only one there on the phone and doing the care, and they'll work with you very well. And of course, this allows the rescuers to talk to dispatch while assessing and treating victims. It becomes a very interactive 911 emergency managed call. And if no mobile phone is available, of course, use current protocols for calling EMS, send a bystander, or whatever we've done in the past or whatever. But I think this is really the tip of the iceberg with mobile phones. I can't wait for video conferencing in dispatchers and that sort of thing. It's around the corner, I'm sure.
Yeah, and they're even talking about drones flying to videotape and then provide some continuous feedback for dispatchers who are looking at you. Also interesting to know, Kevin, about the phones. If you look at your iPhone, if you're maybe using your patient's phone and it's locked, there is an option to make an emergency call. So you can use anyone's phones, even if they're password protected. Also available on iPhone, if you go to that lock screen, is the medical information ID, and so you may actually be able to find out if the person has got allergies, past medical history, emergency contacts. Very useful for the ambulance when it arrives.
Yeah, absolutely. It's not just an outgoing call anymore. It's a source of information on your patients as well.
So CPR is essentially, our approach to this is unchanged, and we want you, everyone's been doing a great job of focusing on quality when teaching courses, and we would really like you to encourage, we'd like to encourage you to continue to do that great work. So again, research still reinforcing that high quality CPR is what actually improves survival rates, and I really have to say that between CPR and AED, all the fancy bells and whistles that somebody might get when the ambulance arrives or in the emergency department does not have the literature that supports it the way CPR and defibrillation do. So we're making a big impact here when we're teaching our courses. So for adults, 5 to 6 centimeters still, which is about 2 inches. And then for child and infant, 5 and 4 centimeters. I personally find centimeters hard to approximate when looking over top. So we're looking at 1/3 of the diameter of the chest to back, that anterior posterior diameter. So making sure you've got a good depth, a rate of 100 to 120, and that we're really minimizing interruptions in CPR and maximizing time on the chest.
Yeah, that's awesome. Again, the focus is that effective CPR because it has such an impact, right? Mm-hmm. Yeah. So here we have some of the key points and of the adult and child and infant CPR that we want to talk about. As Sarah was saying, we're looking at adults, a compression depth of 5 to 6 centimeters, or about 2 inches.
2 inches.
Yeah, 2 inches. Right, and landmarking again is the center of the chest and the sternum, and that compression rate is at rate of 100, 120 beats a minute for all ages, kind of a thing. For children, those being between 1 to 8 years of age, guesstimating, of course, at least 1/3 of the anterior posterior diameter of the chest, or approximately 5 centimeters. I guess that's about that 2 inches again. Yep. And then the center of the chest on the sternum again. And then the 30 compressions in 15 to 18 seconds. And for infants, for those under a year, again, it's that same 1/3 of the anterior diameter of the chest, and 2 fingers on the lower half of the sternum. And that's where there's the big change between child and infant. And of course, it's because of the overall size of the patient that we're talking about. It is important to allow the chest to fully recoil after every compression, and minimize interruptions, really, is what it should say there. I'm not sure why it says frequency, but we should be minimizing interruptions, because that's really important, and because it can lead to decreased blood flow to the vital organs of the body, and anything we can do to combat that. That's why we're here.
Yeah. I think one of the other things that we've kind of heard, push hard, push fast was a slogan, and then it was sort of bantered around that it should be push, not too hard, not too fast, because the pendulum swung a little far. People were getting pretty overzealous with CPR, and so it's actually possible to be too hard and too fast. So really trying to work with people, monitoring CPR during those courses, giving them feedback, and finding teaching tools to provide that. So using metronomes in classes or defibrillators that provide some of that objective information is really helpful for people.
Yeah, awesome. Okay, so, this is your slide.
Yeah, I'm like, hey, it's my turn. So the summary of CPR protocols. So essentially, it's really unchanged. So we always want to encourage people to check for danger, to establish unresponsiveness, and then to begin to activate EMS. So obviously, if you're by yourself, we want you to prioritize getting 911 activated and finding an AED. If there's more than one person around, you can send somebody to do that and bring an AED back while implementing CPR immediately. So once we know that EMS is on its way, opening the airway, making sure that we see either abnormal breathing or an absence of breathing, just quickly 5 seconds, and then getting straight on that chest and beginning high quality CPR. The recommendation for drowning remains that we're going to begin with providing ventilations before CPR, because the biggest driver for that is hypoxia or no oxygen in the body. So we want to begin with that in that circumstance.
Yeah, a little bit of a difference to what's generally recommended, right? But important nonetheless. Excellent. Of course, some of the other notes that we want to provide is, again, allow that chest to fully recoil. That allows for the blood to flow back into the heart for circulation. Without that recoil, you're really stunting the amount of blood that's being flown through the body. Again, minimize the frequency and duration of interruptions. I bet you that's what that other slide said.
Yeah, that must have been it.
Yeah, cut it off there. But that is very important as well. And maximize time on the chest. And even little things in the sequence of doing a rescue can create large interruptions. Like one of the most common ones is actually even just talking to your rescue partner, be it a professional situation or bystander situation. That need to communicate in a crisis can really interrupt those compressions. So keep that in mind, kind of a thing. Of course, immediately start CPR after a shock or a no shock advised when we're doing using an AED or there's no obvious signs of life. We want to immediately get onto that CPR cycle so that we can begin the process of circulating oxygenated blood. The airway, again, is a head tilt chin lift maneuver. And breathing is 2 breaths, 1 second breaths, watch the chest rise and fall, and be deliberate about it. And I find that when I'm training candidates, to get them to focus on that exhalation phase when they're doing their training can help down the road, right? Use regular instead of deep breaths to prevent gastric distension and overinflation of the lungs. It's not a rapid process, it's a drawn out process, that breath that you're providing.
Yeah, being too vigorous with rescue breaths can create a lot of issues. So it's important for people to understand that like blasting people with rescue breaths is actually going to put a lot of air into the stomach, which predisposes people to vomiting and also makes it harder to actually inflate the lungs in the end if we're filling the gut with air. So really important, over a second, nice and slow, just looking for chest rise and then allowing the chest to fall passively. So don't overdo it out there.
Yeah, easier said than done, I think. Yeah.
Okay, well, we've got some exciting changes for you in the first aid world. So the slide you see here has got a number of different topics we're going to look at. And I just want to make sure everyone knows you can follow along in your award guide if you have it in front of you there. But we're going to talk about things that have changed, and if it's not specified, it's going to remain the same. So if you're following along at home, we're just going to highlight some of the things that we either want you to focus on or things that are different, just so you can sort of make sense, because it's going to be fairly brisk that we go through these topics.
Yeah, absolutely. Maybe now's a good time to remind everybody as well that if you have questions as you're going through this presentation with us and you happen to be live with us, thank you very much. But you can also turn to Twitter and hashtag out to us or send out questions to us with the hashtag Lifesaving FA Update. And we're going to be reviewing those questions at the end of our presentation tonight, and hopefully we'll have answers for you there if we didn't have them in the rest of the presentation.
Yeah, absolutely. So for victim positioning, ultimately what they've found is that, you know, you can leave a victim in the position that you found them in, and that's fine. If the breathing can't be assessed, it becomes critical to roll somebody supine or onto their back so that you can begin to manage their airway, because that's likely what they need. if you are leaving them for whatever reason, be it safety or something else, or they're breathing on their own, we want you to put them in the recovery position, which is essentially side lying. That's an excellent position to keep them in until EMS gets there, because it's going to protect their airway as well as keep them comfortable. It doesn't matter which side you have them on. Now, this Haynes position, which stands for high arm in endangered spine, is not the recovery position. It actually, I don't know how frequently it was taught in Manitoba, but it was this special side lying where the person's head was on their arm. And so if you had a suspected spinal injury, it kind of helped you achieve side lying and spinal protection. There's no literature that supports this, so we want to encourage you, if you're concerned about somebody's cervical spine or they've had some sort of an injury, that keep them supine and manually control their head, and we'll talk about that a little bit more. But we're not teaching, if you ever were teaching Haynes, you're not going to be teaching Haynes any longer.
I'll admit, I had to look this one up. I'm like, Haynes, I don't know this one. So.
Well, and I thought they were meaning don't put them side lying anymore. So
right.
when I looked it up, I was like, people can be side lying. Let's just not do this crazy position.
Yeah. Right. Awesome. Speaking of spinal motion restriction, so there's been a lot of talk lately. If you follow, any kind of medical or paramedical websites or Facebook pages, as we all do these days, about removing or eliminating or changing dramatically the way we manage patients that we think have a spinal injury. But so we thought it important from a life savings perspective that we address some of that and talk about what our expectations are in our program. So for a suspected cervical spine injury, we still expect you to manually support the victim's head in a position that limits movement until advanced care arrives. Notice there's not a lot of strong words in there. We've removed any kind of wording like immobilize because of the connotation it has. And in special circumstances, traditional immobilization devices may be used for extrication and movement. And let's cut to the chase. We're talking about a spine board here, right? Mm-hmm. There's not a lot of evidence to support the use of spine boards in EMS and in the hospital settings. Yeah. The same degree of research hasn't been done in the aquatics world yet. But certainly we all know that we use those boards as much as an extrication device, and they can be useful. So we still expect you to use those devices, and there were some notes that come up on that as well later on.
Yeah, we just wanted to prepare you for the fact that the ambulance might be doing different things, and also if you're somebody who's currently in education to be a paramedic, or you work at a different job where you might be using spine boards on land, is that the world has sort of changed, and what they actually found was that people that were immobilized on long boards for a prolonged period of time, actually it was injurious to them because it makes them so sore they end up moving anyway. They develop pressure ulcers, etc. So still applicable to remove somebody from the pool on a backboard. Just don't be surprised when the ambulance gets there, puts a collar on them, gets them onto their stretcher, and doesn't do the full rig for them. It's actually they're more immobilized just like that than they ever were on a longboard. So
yeah, it's a wonderful thing about research. It changes our minds every 5 years or so.
Well,
right?
It gets rid of dogma.
That's
there was
true.
actually no evidence that ever said that people did good on boards. You just thought, I'm going to protect your spine. I'm going to strap you down to this hard thing and make it impossible for your spine to move. But we know now, and the literature says that actually wasn't what that was doing at all. It was actually making it worse. Yeah.
Evidence-based as opposed to, that seems like it would work.
Evidence-based.
That's right.
Yeah.
Okay, concussions is another thing we should talk about. It's in the news a lot lately, and we're learning more and more about concussions. And so some of the things that we wanted to address is, first off, the signs and symptoms for concussion include things like a loss of consciousness or a change in the level of consciousness, confusion, loss of memory, dizziness, a headache, vision problems, unsteadiness, and nausea. And I guess this is also, we have to say, it's associated with some form of a head trauma of some kind. And it can be very minor to actually quite dramatic. And concussion can be likely in both circumstances. It's just very dependent. Victims can suffer from all, some, or none of these signs and symptoms, of course. And the goal here when we're talking about concussions and first aid care is call EMS if a victim loses consciousness from a blow to the head. And even that's true if it's not a sustained unconsciousness. Even if it's only momentary, that call should be there. And anyone who sustains a head injury should discontinue the activity and seek medical care. Now, that's the best option for those patients that are seemingly fine, but had the incident, had some kind of a head trauma, and we want to make sure that they get checked out. And they really need to take a time out. That's a lot. I think there's a lot of information coming out of professional sports that that was really the problems that they saw was these patients continually trying to perform and getting re-injured before their body had a chance to heal.
I think the other thing is that we're seeing more and more with athletic therapy that there's different scales and tools now that they use to evaluate what happened, how many previous concussions, what your symptoms are, and that really guides how they directly you sit on the bench for a bit versus you go to the doctor versus you call 911. We do not want that content brought out in programming. In fact, that's specialty professional knowledge. So anybody who is in school, if you have your own extra knowledge, that's fabulous. Please don't deliver that to your candidates. We just want people to know these are signs and symptoms that might be associated with issues. If it's bad, if they're unconscious or they're massively confused and it seems bad, you should phone 911. And if it seems okay, you can ask them to sit out or go to a doctor or whatever. But we want to encourage people to just recognize it more as an issue.
Yeah.
Awesome. So for anaphylaxis, things have not changed in terms of the treatment for anaphylaxis, but we're really starting to recognize that we want to break down some of the barriers or the perceived stress around, oh my goodness, it's somebody's medicine and how can I do it and only one and all of these things. Because the reality is that if somebody is truly experiencing an anaphylactic response, is that it is life-threatening, and we really want to encourage and empower people to act in a way that could potentially save a life. So as always, number one is to call 911 and find their epinephrine and help them to take it. If they actually have more than one EpiPen, or they have the twin inject, which gives you 2 doses, and we're starting to see more and more frequency that people actually have more than one auto injecting device on their person, or they should if they have an allergy, that there can be a second dose given if the symptoms are not improved or if they're worsening after 5 minutes. So we really want to make sure people feel comfortable. It's okay if the person is going to die for them to have another shot of epi.
Yeah, and I feel like we should address beyond the medical indications here some of the stuff that's been in the news lately with EpiPens and the escalating costs and the politics behind all of that, and just simply to say that shouldn't factor into your decision-making tree on when to provide epi for a patient. This is a life-threatening emergency, and that's why they have it with them, is for this moment. Don't worry about the financial implications that may cause, but if they're in need, they are in need.
The other thing that I just want to make sure people know is, just through professional experience as a nurse, the number one issue is people not taking their taking their epi. I've triaged countless patients that come up in full anaphylactic shock, holding their EpiPen in their hand because they were too frightened to take it. They didn't receive teaching from the pharmacist. They've never had a reaction this bad before. They didn't know if it was bad enough or whatever. So it is totally okay if you see the signs and they feel like it might be happening. A shot of epi isn't going to harm anybody, and it's potentially going to save a life. I really wouldn't hesitate for somebody to have a dose of epi. It's going to be okay.
Yeah, err on that side for sure.
Err on the side of caution, people.
For sure. Awesome. Okay, so let's talk a little bit about chest pain. ASA specifically is not there to make the pain go away. That's not why we're talking ASA at all. So let's get that out of our heads. ASA helps stop clotting in the arteries, and that's the action that we're talking about. And the goal with this is to assist a victim in taking their own ASA. And that's true of, if they're not allergic to it, if they don't have a history of recent active bleeding, I had a bloody nose 2.5 weeks ago. That's not what we're talking about. We're We're talking about active right now. And unless their doctor has advised against them taking ASA. And I think, these are 3 important things to talk about, but it reinforces the fact that we're still using the person's own ASA.
Yeah.
So, if they're carrying ASA, most of our work in evaluating that they need this or should have it is done.
It should be reduced for sure.
Yeah, but we need to still check in on these 3 things kind of thing.
Just want to empower everybody out there to know that out of anything that can happen to somebody who's having chest pain or a heart attack, is that aspirin has got the best literature that supports it. In fact, it is the most important thing somebody can have, and that's up against all the fancy medications and angiograms and whatever that they might have at the hospital. Nothing has got more evidence than aspirin. So we really want to encourage you, if they have it, it's so great. The earlier, the better.
Yeah, it's amazing too. It's one of our 100-year-old meds.
Yeah.
And it's still kicking butt.
Still ruling.
It's still ruling, yeah. Nitro, a patient that's prescribed nitro can take up to 3 doses at intervals of 5 minutes. Immediately, and then 5 minutes spaced between the second and the third. And really, the only contraindication to that one is if they can't take it themselves, we're not going to give it to them.
Yeah.
Kind of a thing.
If they've got a reduced level of consciousness,
Right.
I would really stay away from it. And then I also just want to point out, in previous publications we've had, it said, intervals of 3 to 5, and I would just like to reinforce with people, it is 5 minutes. I would not give it more often than that. It can really decrease somebody's blood pressure and be dangerous. So 3 doses, 5-minute intervals.
Right. So then just to recap on that, it is 1 now at 0 minutes.
0 times 0.
Yeah. 1 in 5 minutes.
Yep.
And then 1 and another 5 minutes.
That's right, Kevin.
There we go.
You got it.
Great.
Yeah.
Okay. Oh yeah, right.
Right.
Also, victims
Before you give it.
Yeah, before you give it, victims should not be taking nitroglycerin if they're taking some erectile dysfunction drugs within the last 24 hours, because those 2 drugs can compound and cause problems for them with blood pressure maintenance.
Yeah, and I do just want to make a note here that it's important to refer to them as erectile dysfunction drugs. I know that there's been some publications in the past that have said performance enhancing, and I just want to, reaffirm with everyone that that's actually very, very confusing language to use around it, because it's made people think about anabolic steroids or whatever else.
Yeah.
And we're talking about medications that are designed to deal with erectile dysfunction, so we're going to have to use appropriate language to make sure patients understand what we're talking about when
be
we're
specific.
asking them. Let's be specific.
Yeah, performance enhancing. I'm not an athlete.
Yeah, I know.
I'm not an
What
Olympian.
kind of performance are you talking about?
That's right.
Okay.
I play the violin. All right, stroke assessment.
So strokes, this is something that, you've noticed there's probably a lot of public campaign out there right now encouraging people to recognize it. And historically, this has been a big issue, that somebody's had a facial droop and unable to use an arm, and they get to the hospital at 12 hours, and there's really not a lot anybody can do. And so we really have been encouraging the public, as well as anybody taking our courses, that we want people to understand that if they recognize symptoms, that this is an emergent medical condition, and we want people to be assessed at an emergency department less than 3 hours from time of onset. Now, we're going to see some variability with that time frame. I don't want to get anybody to get hung up on it. So, because it's really as fast as possible they should get there. And it doesn't matter if it's 4.5 hours is what Manitoba is using. The big brass tacks of this, everybody, is if somebody seems like they're having a stroke, we want to activate EMS and get them to an emergency department.
Yeah. Again, a protocol designed to encourage people calling 911.
That's right. That's all it is in the end. Just pick up the phone. So the acronym that you've seen in the media is FAST. So it stands for face, arm, speech, and time. And this is a really easy tool to administer to see if somebody seems like they're having a stroke. So face or facial droop, you can see in the picture there, it's very subtle, sometimes more dramatic. If you're not sure, you can ask the person to smile and show their teeth. And if they're not able to do that on one side of their mouth, that's pretty suspicious for a facial droop, I would say. And especially in elderly people, I find that test really useful when it's difficult just to see based on their skin, etc., if they have a drooping mouth. Arm weakness, so again, this is one arm more than the other. So you can ask them to squeeze your hands or to raise both of their arms up close their eyes, and if one drips down, then that's considered an arm weakness. Speech difficulty, and this can just be in conversation. I know we've taught in the past, asked them to say stuff like, you can't teach an old dog new tricks. I think that's kind of an ageist thing to ask somebody to say personally. But we just actually want to see if they're able to utilize their speech in an appropriate way. And if it's slurring, however you achieve that, that's up to you. And then if you one or more of these are met, that you pick up the phone. So in the past, we've talked about stroke and transient ischemic attacks, or TIAs, and we've really robustly talked about them in the program. I would actually like to see us move away from that. I think what you just need to know is that if somebody says they've had a TIA, that just means that they're at really high risk of having a stroke.
Yeah.
But the only way to really tell, even if the symptoms resolve, is by getting a CT scan.
Right.
So it's really not for us to say if they look strokey, we're just going to call 911 and then they'll send the person to the scanner.
There you go.
There you go.
Okay, hypoglycemia or low blood sugar here, and basically for this one, the preferred treatment option is glucose tablets if you've got them. If glucose tablets are unavailable, you can use things like Mentos or Skittles or jelly beans or orange juice. The one thing that always comes to mind, though, I think of, Sarah, when I think of these is any choking risk.
Yeah.
You really need to have a patient that's coherent enough to follow instructions when you're feeding them stuff. So, and of course these people are in crisis, so coherency is one of the problems. So you really got to be careful with that.
I'd say it would be reasonable, Kev, just to make sure that they're able to, like if they're mentating well enough to swallow. Like if your blood sugar is low, you might be unconscious, you might be near unconscious, and you might be able to follow commands, you might not. If they're at the point where they can't follow commands, just phone 911, because there's all kinds of solutions there. But maybe just get them to have a sip of water first, and just show they're trustworthy.
That's a good idea.
That I can have a sip of water, I can swallow it, I know I understand how to follow those, so before I put tiny Skittles in your mouth or Mentos, that I know you're going to be able to know what to do with them.
Here's a handful of Skittles.
Let's see how it goes.
Yeah, exactly.
2 problems.
Yeah, exactly. So, and of course, it could take 10 to 15 minutes for blood sugar levels to return to normal. Yeah. So this isn't an immediate thing, but keep that in mind and monitor them over that time period. And of course, glucose may be repeated if symptoms persist, after 10 minutes, kind of a thing. And that's the guidelines that we want you to think about when we're talking about hypoglycemia management.
Yeah, it's also good to tell people time to have a nice big sandwich, or once the glucose comes up, let's give you some complex carbohydrates, and then you can actually maintain that blood sugar. So nothing like a grilled cheese.
Yeah, follow it up. That's a good call. All right.
Okay, so for severe bleeding, so this is something that we've had a little bit of a change about, and we're going to give you a demonstration shortly. But number one, what has not changed is that your first line of control is applying direct, firm pressure to the area. So again, gloves on, getting gauze, and if gauze is not available, or abdominal pads, that whatever you can to stop it is going to be critical, and that's the first line of defense. We don't want to discourage people to using tourniquets, because this can be life preserving. And so we're going to give you a demonstration so that you can see a few of these tips and techniques with it. But you're going to be asking your candidates to reach for this if direct pressure fails and bleeding is ongoing despite all of those things that you've done already. If the wound is in an inaccessible space, so maybe you can't actually apply direct pressure, so maybe the person is being crushed, there's something
trapped.
heavy, you can see the blood, they're trapped, and you're not able to apply direct pressure to the wound itself. If the person has got multiple injuries and it's becoming difficult to manage that one in particular in the context of all the other, if you have a mass casualty incident and your resources are limited, and of course if you're in remote locations and let's say you're trying to drag a friend through the bush who's got a deadly bleed, sitting in one spot applying direct pressure for eternity is not going to save someone's life. So putting on a tourniquet and trying to figure out how to get them out is going to be key. So those are just a few ideas for when you might
Yeah.
need it.
And it's interesting, I think, that when we think about tourniquets and major bleeding management, we've kind of come full circle. Like after the Second World War, it became a very common practice in first aid training and courses. And then it kind of fell to the wayside with new fancy treatments and management approaches on a medical side anyway, in that the tourniquet kind of disappeared in first aid for a great number of years. And then, lo and behold, the 21st century and a pocket full of wars.
It's back.
And it's back. And we remembered, oh yeah, that's why we put tourniquets on.
I think we also created a lot of fear. Ooh, don't put it on. Don't put it on. Well, if it's more bleeding than you can control, put it on, because the risk is higher that the person dies. And especially if you're in the city or you're somewhere with good EMS access, if you put it on and they come and they evaluate it and they take it off, well then that's okay. We want you to use it if you feel like you're at that point.
Yeah,
so.
When you can't control it, get the tourniquet going.
Put a tourniquet, get it going.
So how? Well, the tourniquet, some guidelines here is, first off, is we want it to be about 5 centimeters wide. That's about 2 inches, right?
Yep,
yeah, right.
Exactly, Kev.
Wow.
Yeah.
You want it to be placed as close to the wound as possible, but obviously on the heart side of that wound.
Yes.
Right?
Yeah.
So, between the heart and the wound, just so we're clear. And applied directly over exposed skin to avoid slipping. That's important because you never know. Somebody could have jewelry on or something that could cause problems with that application of a tourniquet.
Yeah.
So you want effectiveness determined by the cessation of bleeding.
Yeah.
So basically turn until it stops bleeding, or apply it until it stops bleeding. And the wider tourniquets do not necessarily reduce damage to the limb, but we want to try to have something that's at least wide enough. The worst tourniquet I ever saw was baling twine.
I was going to chicken wire.
Oh, yeah, that would be terrible too.
No.
So one teaching point is that candidates do not demonstrate the use of a tourniquet on another candidate or themselves.
Yeah, safety
so
alert.
We've gone to great lengths to in our demonstration that's going to start right away here. So we're going to introduce Megan and Ashley are going to be helping us out here. And you'll see that they've got a wonderful mannequin to demonstrate our tourniquet application.
Okay, we've got a major bleed here.
Megan, I'm having trouble controlling this bleed.
Okay, I've got a tourniquet that is a triangular bandage that I'm going to apply above the wound, closer to the heart, skin to skin. I've got a stick to use as leverage, so I'm going to tie bandage around it, just to make sure that it's nice and tight. You're still applying direct pressure. Okay. The bleeding seems to be slowing down. You have more control over it. Okay, can you hold on to that while I'm going to secure it in place? Using another triangular bandage. And a figure 8 just to make sure that it stays nicely in place. Okay, now the bleeding seems we're under control, and you can tell that circulation has decreased slightly to the distal part of the injury.
Okay, wonderful. Thanks very much. That was awesome work there.
That was awesome. And just a little reminder out there, just if anyone's been caught up before in the pulse, no pulse, the tourniquet really is applied until the bleeding, crank it until the faucet's off and there's no bleeding.
Yeah.
And really, you're looking actually for a loss of circulation to the limb, because that means the bleeding is going to be controlled. So if you could feel pulses in the feet or whatever before, you'd be looking to not. But the reality is we just want you to turn it until it stops bleeding. So that was a lovely demonstration.
Awesome.
Great.
Yeah, so just before we jump into open chest wounds, I just want to remind everybody again that if you are following along at home, jump on the old Twitter and type in the hashtag Lifesaving FA Update if you have questions for us tonight. At the end, we're going to be looking at those tweets. Tweets of all kinds we'll be answering, I'm hoping.
Yeah.
I'm hoping
too.
Awesome.
Okay, we're ready?
You betcha.
Okay, well, we're going to talk about open chest wounds or sucking chest wounds or open pneumothorax, all things you may have heard. So change for this here, historically we have trained people to use the semi-occlusive dressing, and that was to, get a Ziploc bag or some sort of plastic or whatever and tape it on 3 sides. This is no longer a recommendation, so we want you to stop teaching this in the programs. And the reason for this is that actually the consequence is that it can cause the injury to become worse, because many of these semi-occlusive dressings became saturated to the skin and made it develop into a tension pneumothorax or a collapsed lung, and that is life-threatening, even more life-threatening than the open pneumothorax. So if there is bleeding and it's minor, you can just leave it open to air. That's okay. Right. EMS will deal with it. If there's bleeding that seems difficult to control or it's sort of going everywhere to contain it, you can put some dry gauze over it, but then you just need to be, this chest seems to be in the way of this blood point, but we just want you to make sure that the dressing doesn't become saturated with blood, because that also is going to create an occlusive barrier, put them at risk for a closed pneumo.
Yeah. And I think again, you addressed it there, but I want to add is that I think that the old method of the 3-sided tape dressing was a treatment of best intentions, right? But in reality, it never played out that way because of the realistic complications with an injury of this type. And open chest wounds aren't caused by, accidentally boutonniere pricks. They're big nasty holes, right? They're big stab wounds. They're falling onto something injuries or gunshot wounds, right? So,
there's a lot going on with them, and I think that it was probably, again, an ideal fix in the mind. I think that there's a lot of literature that says it's actually dangerous.
Right.
And so we, just like the spine boards, there was no literature that I don't think ever really supported this as a concept. So we want you to stop teaching it. It's just going to be better to leave it open to air. Yeah. Or put a little bit of gauze over top. It got easier for your candidates. Isn't that fun?
Yeah. Awesome. So let's talk a little bit about dental injuries. So rescuers should not attempt to reinsert an avulsed tooth or a knocked out tooth. This was a first aid recommendation at one point. Was just
try to put it back in.
Yeah, just
what
put this
year?
Foreign object. Oh, I'm not sure. I can't remember. But here, put this foreign object back into your airway and keep it there. So do not clean the avulsed tooth because this can actually lead to risk of loss or damage. And basically place the tooth in one of the following: either a balanced salt solution or egg whites, or coconut water, or whole milk, or if none of those are available, store the tooth in its cut off from my saliva. Yeah, so lots of fun. Obviously, patient's tooth, patient's saliva, not mine, right?
Patient's own.
Patient's own, that's right. Okay.
This clipboard's killing us here.
Yeah, I'm not sure why it moved over there, but my apologies.
Okay, so just quickly, up to the minute facts on fracture management. This clipboard actually here, this is fun. This is the fall on the outstretched hand, or foosh. That's the abbrev in the hospital world for it. It's not good to fall on outstretched hands, people.
Yeah, that's how I broke my arm.
Oh, Cav, that was hard times. Okay, so we want you to encourage your candidates to remember that, we shouldn't be going through big lists of, sprains, strains, fractures, how to differentiate, because the reality is that it's really difficult to, and the only thing that really makes you able to differentiate is an x-ray. So any swelling, deformity, or injury that has created pain in that area, we want people to recognize that's a potential fracture and to treat it accordingly. Now, don't move it or try to straighten the extremity.
Yeah.
So we want to reinforce keeping it in the position found. And here's a beauty. Don't splint it. And I
Yeah.
have to say, we never really did well at this. I mean, I remember teaching lifeguarding courses and first aid courses where I had a series of wooden sticks and cravats, and you just think about how much damage we actually did creating a really lackluster splint just for the paramedics to like literally cut it off
Cut
with
it
trauma
off,
shears
yeah.
2 minutes later. It didn't make a lot of sense, did it?
No, and I agree. And I always use the perspective of if the patient needs to be moved, then you need to stabilize a fracture. If they don't need to be moved, then you don't need to stabilize the fracture.
Right.
Them not moving is stabilizing the fracture. So
Yeah.
leave it be if that's the case.
And leave them be if
Yeah.
you can, unless there's something dangerous going on. And most people are going to actually self-splint really
Right.
well.
Yeah.
I've rarely met a patient that hasn't been doing a way better job than I'm going to protecting their own fracture. They're highly motivated, more than I am,
Yeah, right.
probably in a lot of ways. So for applying ice, just again reinforcing, making sure that it's not ice straight up
Yeah.
on the skin, because that's obviously not going to be good. So a nice clean towel or something of that sort. Again, as Kev was saying there, if you need to move them, maybe you'll consider it, or like a splint or people helping to hold it or whatever, that's fine. And again, this is something like a simple fracture is not life-threatening. Lots of people walk to the hospital,
Right.
take cars, whatever. So you can kind of get a sense of what the person needs. If you have an extremity that looks pale, is cold, there's a loss of sensation or a loss of pulse, or it's significantly ankulated, phone 911. And the reality is that person's probably not I'm going to get in my car and go to the
Right.
hospital kind of
Yeah.
person anyway. So you really should know them when you see them. But if you don't think blood's getting below this side of the injury, it's probably not. And then that is a limb-threatening emergency.
Right. I think the other thing that's going to motivate EMS for a fracture, to be honest with you, is going to be pain. You know, the patient's going to be complaining of lots of pain, and that's going to spur any rescuer into calling 911, regardless of whether there's circulation or not.
That's right.
So consider that, and that's a reasonable reason to call 911, right?
Yeah.
So, okay.
So splints, really, at the end of the day, there's no massive science to this, because the only thing that really, really works super well is a cast or a
Right,
commercial
yeah,
device. So
yeah.
we don't need to like save the world here. But if you do need to put a splint on, the big priorities is that it limits pain, not creates a whole bunch of it, reduces the chance for further injury, and will help you get the person to more help. So if it does those three things, then you've got a fine looking splint.
Yeah, and think about your motives for putting on a splint. It's obvious then you've decided to move this patient, or there's a necessity to move the patient.
Yeah.
So think about splinting in such a manner that's going to help you move the patient.
Yes.
Right? It doesn't make any sense to splint a patient and then it's impossible to move them.
Yeah.
It was defeatist.
Yes, exactly.
Frostbite. Okay, that's a nasty picture, right?
It's coming up.
Yeah,
With
yeah.
the
Winter is coming. There you go. So frostbite, basically with this one, the key is rapid rewarming in warm baths. So you want water to be between 37 and 42 degrees Celsius. That should be just lukewarm to the touch. It's not hot water, really.
Put on some candles, listen to some Sarah McLachlan, and just relax.
That's right. Yeah, chemical warmers should not be used because again, they're going to really try to heat things up more than that, and that's when you can start to see tissue damage occurring to areas that are severely frostbitten. So a temporary warming if there is no risk of refreezing. So basically, I always evaluate that as I've eliminated the danger, right? I've removed them from cold. Now I can start to rewarm them. If I can't remove them from cold, rewarming is not my priority. Removing them from cold is.
Yeah.
So think about it from that perspective.
And that probably doesn't mean the guy here with the black fingers, keep that hand in -40 straight up. Like you
Right.
could slap a mitt on that or something and protect it from
Right.
getting worse without actively rewarming
Yeah,
it.
oh, totally. Yeah, absolutely. And for severe frostbite, rewarming should be done within 24 hours. So I guess that's really neither here nor there, other than it's just good to know.
Yeah.
Because
Hospital material.
Yeah, hospital material. Time
Yeah.
is going to tick whether you do it or not, right?
Yeah.
So
Yeah.
After rewarming the parts, protect them from refreezing, and that's key because obviously they're damaged and now they're very susceptible, right? Dress them with sterile gauze placed between the digits if you need to, if you can, and transport the victim quickly to medical care, kind of a thing. So that's frostbite for you.
Okay, so don't you love when things get easier? Minor wound
Yeah,
care.
eh?
The whole world just got easier for us. We're just gonna get the person to a clean running water tap and irrigate the wound.
Yeah.
So it was found to be more effective for saline, and that's simply because of the pressure of water coming out of a faucet compared to, lightly drizzling something from a saline bottle or an IV bag,
Right,
or maybe
yeah.
people didn't have access to saline and it discouraged them from using anything. So just as you can see in the picture here, just letting it run under the faucet for a little bit. Don't get crazy, soap or Ajax or
Right.
whatever. Just water. It's fine.
Nice, easy, simple, right?
Yeah. Your candidates will love it.
Yeah, so let's talk a little bit about ongoing science and research. So the Lifesaving Society reviews and analyzes new and emerging research in the fields of first aid, treatment, and drowning resuscitation. And that's why we participate in groups like the Canadian Consensus Task Force on developing these standards and reviewing the literature and research that's out there. Instructors should teach content from current resources provided by the Lifesaving Society. And the Lifesaving Society will notify instructors when there are changes to first aid and resuscitation protocols. And that's really what our responsibility in all this is making sure that you have access to the new resources and material. So I can tell you, Sarah, that right now we have the new first materials that are just coming into the office. We have one that we would hope would be available for us tonight, but it's not ready yet, but I'm sure it'll be here by the end of the week, and then the instructors can get access to purchasing those materials that they need to ensure that they have the right resources for when they're teaching. Mm-hmm. So, and I just want to take another minute to remind everybody to keep tweeting at us there at hashtag LifesavingFA update if you have any questions. And now we're going to go on to one of Sarah's favorite topics.
Ooh, my favorite. So we're going to just deep dive into some of these aspects. I know we've touched on CPR before this, but we're going to sort of go through some of these changes for healthcare providers, CPR. And so we're going to tackle each of these things on the bulleted list as we go here. So number one, the chain of survival. So two separate chains of survival reflect the differences when responding to cardiac arrest in or out of the hospital, and that's the big thing. As instructors, you might be providing healthcare provider CPR to, say, a group of lifeguards that work in a certain area or the beach or whatever. You also might be providing a program to nurses or health careers that work in a hospital or paramedics, and that we need to reflect the fact that there's going to be different chains of survival and different behaviors because of that. So the out-of-hospital chain of survival is going to be taught in the Lifesaving Society programs, and the healthcare provider instructors can reference the in-hospital chain of survival if they're teaching or recertifying those types of employees.
And it's worth noting that not all Lifesaving Society instructors can deliver healthcare provider CPR. In Manitoba, we have that program tied to our National Lifeguard Instructor network. So if you are a National Lifeguard Instructor, the healthcare provider information and the differences between the in and out of hospital chains of survival are going to be important for you to be aware of.
Okay, perfect. So the out-of-hospital chain of survival is seen here. So again, recognizing what's happening and activating EMS immediately, beginning immediate high-quality CPR, providing rapid defibrillation through use of an AED, having the ambulance arrive with basic and or advanced skills, and then getting the person to a hospital. And the in-hospital chain of survival, may as well finish up. So surveillance and prevention, and that's ultimately meaning that we're going to figure out who has suffered from a cardiac arrest in a timely manner.
Right.
So if somebody's sitting in a hospital room, that we have a mechanism in place that we're going to be able to recognize that that's happened. Once we know it has, that there is a response system. So in the hospital, this is often referred to as a code blue, and there would be a button or a mechanism to alert the hospital that there's an issue that's happened requiring resuscitation, that the team is able to provide immediately high quality CPR, defibrillation, and that they find their way to post-arrest care. So,
and I think for this chain of survival, for the in-hospital chain of survival, the real motives were that hospital personnel just didn't like the ambulance in the chain of survival. You know, it just looks kind of funny when you're standing in an ER and there's an ambulance in your chain of survival.
Yeah, that's
right?
true. Now, that's always actually really, really true for hospitals in Winnipeg. But it's actually interesting because hospitals outside of the city may actually be phoning 911 for additional help.
That's right.
Yeah.
That's right. For
so
sure.
we would never want to discourage that, especially facilities that are currently not. They don't have a physician working at them, and they may actually be calling 911. But that's a great point, Kevin.
That's a good point too. That there are a variety of healthcare facilities that this can apply to in various forms.
Yes.
Right. You know, doctors' offices is going to be another one that's a different kind of approach to things. Right.
That's right.
Yeah. Speaking of approach, let's talk about the team approach.
It's my favorite.
Yeah, eh?
Yeah.
Okay, well, the team of trained rescuers may be used to choreograph an approach to resuscitation, and healthcare provider training should focus on building the team as each member arrives or delegates the role of multiple resuscitation, multiple rescuers are present. This better reflects real-life applications in the ambulance or hospital settings. And certainly if you are in a situation, in a professional rescue situation, that's what we're talking about here, practicing that choreographed response is really important, because that's what can make you very effective as a team and reduce those interruptions and be better coordinated at that rescue. So we're going to go to a quick demonstration here from our demo team. So we'll introduce, we got Megan, Ashley, and Chris that are going to be doing a quick demo for us on resuscitation. Take it away, team.
Okay, so I'm going to be checking my surroundings. I'm not seeing anything that can hurt myself or this victim, but I do see a victim that may be unconscious. I'm going to tap and shout, "Hey, are you all right? Are you okay? Are you all right? Are you okay?" Okay, they're not responding. So Ashley, we're going to need a 911 call. Tell them that we've got an unconscious adult at the Lifesaving Society, and return to me as soon as you made that call.
Okay.
Do you need first aid kit?
Yes, please,
okay,
Chris.
not a problem. I'll go grab them.
Okay. I'm going to check. And I've established that they aren't breathing, so I'm going to start with CPR. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 2, 3, 4, 5, 6, 7, 8, 9, 20. 4, 5, 6, 7, 8, 9, 30. I've got my mask. And I seal, and I'm going to give 2 breaths. Breath. Breath. And I see that it went in.
I've called 911. What do you need me to do?
3, 4, 5. We're going to have you do breaths after these compressions. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 1, 2, 3, 4, 5, 6, 7, 8, 9, 30.
Breath. Breath.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 20. 2, 3, 4, 5, 6, 7, 8, 9, 30.
Breath. Breath.
After this one, I'm just going to have you switch to this other side so that we can do a nice switch, okay? 21, 6, 7, 8, 9, 30. Keep doing your breaths.
Breath.
But now
Breath.
switch to the other side of the head. 2, 5, 6, 7, 8, 10. 20.
After this set of compressions,
30.
I'll take over.
Okay, breaths. Breath, breath.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16,
Okay.
17, 18,
Sorry, it took me a
19,
while.
20,
Okay, we've got the AED here now.
24, 25,
Keep going,
26,
I'll get it set
27,
up.
28, 29, 30.
Breath, breath.
1, 2, 3, 4, 5, 6, 7, 8,
Yeah, thanks.
9,
Thanks,
10,
Megan.
11,
I'm gonna lift up
12,
the shirt
13,
here.
14,
Keep going.
15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Breath,
Fly
Breath.
pads as shown in the pictures. Apply pads as shown in the pictures. Press pads firmly on skin.
20,
Apply pads as shown. Press pads firmly on skin. Do not touch the patient.
Okay.
Analyzing heart
I'm clear, you're
rhythm.
clear, everybody clear?
Do not touch the patient. Analyzing heart rhythm. Shock advised.
Okay, I got the
Do
shot,
not
everybody
touch the
clear?
patient.
Cleared.
Press the flashing shock button. Shock delivered.
Keep going.
Begin CPR.
1, 2, 3, 4, 5, 6, 7, 8, 9,
10. 20. 30. Give 2 breaths.
Let me know when you
Breath.
need me to switch in.
breath. I'm feeling pretty tired. Do you want to
Oh,
take
okay.
over?
Yep.
Thank you. I'm controlling any crowds. Seems pretty calm right now, though.
20. 30. Give 2 breaths.
Breath. Breath.
Ten. 20.
How long did they say the ambulance would be?
30. Give 2 breaths.
Breath.
7 minutes out.
7 minutes out. Okay. I think I can hear the siren in the distance.
Ten. 20.
If you're getting tired, let me know.
Okay, great guys, thanks very much.
30.
We appreciate that demo there.
Kev, you know what I really loved about that? So I think that that shows that, you know, there's a lot of value to rehearsing team process, but there's really something fluid about it. And what you really need to be able to do is communicate with the other rescuers. Who's tired? What do you need? Where are the gaps? How can we work together as a team? Number one. The other thing that I thought was really excellent about that is you can really tell when a metronome gets introduced.
No kidding, eh?
And I think that what that's really shown us is that, you know, historically when we focused on rate and depth and all of these things, now, you know, before we went all of us too slow.
Right.
And now it's all of us too fast. And man, can you ever tell when a metronome goes on? And we would like to encourage all of you as instructors as well as potentially rescuers, if you're not around an AED that actually is equipped with a metronome, that there are all types of free apps that you can get on your phone. I have CPR Tempo, and you can just put it on and it should just be on the entire time because your CPR quality goes up exponentially when you introduce an objective tool like that.
Yeah, very handy, like you said, objective to take out the guesswork and remove a little bit of the hype or stress of the situation, you know, thanks to that mechanical aid.
Yeah.
You know, and I know that you and I are both aware of a resuscitation that happened at a lifeguarded environment this summer where a metronome was used by those lifeguards. And it was one of the things that advanced responders responding to the scene were actually praising the team about using was that metronome to help guide them through the resuscitative process. So,
yeah, absolutely. And I mean, I think historically we've always said to people, well, you can sing the song Staying Alive. Well, when somebody is dead in front of you, you sing that song pretty fast.
Yeah, pretty fast, exactly. Okay.
So simultaneous assessment, and so again, this is we're in the healthcare provider section. So a healthcare provider can check breathing and pulse together or separately, and this is going to be key depending on where they are and what their background is. So we want them to reduce the time that they're spending on that, but if they choose to do it together, that's okay. If they choose to do it separately, that's okay too. But the overall, it needs to be done for less than 10 seconds because this is a situation that requires action.
Yeah, again, focus on reducing the interruptions.
That's right. Yeah.
Ventilations and CPR. If a single rescuer is performing CPR, the mouth-to-mask techniques for ventilation is preferred, and that really has to do with how difficult it is to get an effective seal with a BVM and a mask component to it. It takes lots and lots of practice, and it is best done with multiple providers, actually. So I know that we'll be taking a look at that in a little bit yet, but we've got a few more slides to cruise through yet. So again, where there's 2 or more rescuers supporting ventilation, 2-person bag valve mask technique is preferred. So
yeah, it's actually optimum. None of us do it well as one person, so I'll tell you that right now. So for the child and infant witness versus unwitnessed arrest, so the lone care provider that's witnessed child or infant collapse should immediately call 911 and obtain an AED if it's a witnessed. And if it's unwitnessed, they should do 2 minutes of CPR and then activate EMS. And the reason for this is it's likely hypoxia or low oxygen that's caused this. 2 minutes may actually be life-saving. So then you would give them that opportunity to introduce some oxygen to their body, see how they respond. And if they're still pulseless, then we can move to call 911.
Yeah, absolutely. So just a bit of a summary chart there for the overall process there is, again, the scene assessment remains the same, which is, check for dangers and what happened. Recognition, again, is the same across the spectrum. Are they unresponsive to verbal and painful stimulus? And then the EMS, and that's where we see the change start to occur there. With single rescuers, activate EMS and retrieve an AED with an adult. And with children with single rescuers, unwitnessed, 2 minutes of CPR, then activate EMS and retrieve an AED. And it's just because of that resuscitative time period that can make the difference because of the likely causes of arrest in children and infants. And of course, assess the airway and breathing. And perform a quick check for absent or if abnormal breathing, but not more than 10 seconds because we want to manage those interruptions. And the treatment, if breathing is absent, begin CPR, right? And that indication hasn't changed. And begin CPR if no pulse or pulse is less than 60 beats a minute with poor perfusion in infants and children. Poor perfusion, I think the best thing is going to be color. How are they going to look is the best way to assess that kind of a thing. And
kids with heart rates less than 60 are going to look poor.
Yeah, that's pretty rough for a kid. Yeah, absolutely.
So here's just a little summary of healthcare provider CPR protocols. So again, we're not going to beat CPR to death here. So again, we're going back to those same indicators for quality. So recoil, minimizing interruptions, maximizing time on the chest. Multiple rescuers, and likely in this type of a situation, either in hospital or for training of paramedics or whatever, that there's going to be multiple rescuers. And so rotating compressors every 2 minutes is actually mandatory. I don't care how you feel. I don't care if you think you can do CPR for 20 minutes. The literature supports that people's quality goes down after 2 minutes, so that's mandatory. Now, the other thing I'll note is that if you are actually in an environment that has got lots of people, that there are ways that you can actually rotate compressors every set of 30 with minimizing interruptions, just having a lineup, having a well-oiled machine. So that's going to require a team leader, and that's definitely, we can show you techniques for that in courses that we do coming up, but I think what I want people to know is it's at least every 2 minutes or more often as best as you're able to manage, again, but making sure we're minimizing those interruptions. AED pads should be applied while CPR is ongoing, so don't stop compressions to get the pads on. And same as with the lay rescue or CPR, as soon as there's a shock, no shock, that we're getting right back on the chest and giving them more CPR. For management of the airway, obviously we're still using the head tilt chin lift. The suspected spinal injury, that jaw thrust, has survived in the healthcare provider program, but really we want people to realize that if you're not adequately managing the airway and ventilating the patient, that you must, because nobody's going to live through that. So
yeah, I always think of that as a one and done, right? I'm going to try the jaw thrust once.
Yeah. If
it doesn't work, okay, airway's too important. We got to get air into this patient.
Yeah.
We go to a head tilt chin lift.
I think there's probably lots of people that haven't survived things that may have been survivable because we've been so afraid of spinal injuries, suspected or actual, and it's caused us not to support airway, breathing, circulation. Right. So we always need to remember that those are the key priorities. So for the ventilation support, so 2 breaths, using just a regular breath over 1 second, not blasting them full of air, not putting a ton of air into their belly. And in the circumstance where the person is going to be getting ventilatory support without CPR, so they have a pulse, but they just need help with breathing, that it's going to be the 1 breath every 5 seconds or 1 every 3 for children. Right. And of course, as always, as soon as you can attach a defibrillator, you should be attaching a defibrillator.
Go, go, go.
Go, go, go.
Okay, here's some summary of changes for drowning and water rescue. So we'll take a look at in the next... do we have a demonstration coming up? No, I believe it's in a bit.
Oh, sorry.
That's okay.
Okay, sorry, Kev.
No, hey, it's all right.
Just want to make sure we're on track.
I gotcha, yeah. So anyway, back to summary of drowning and water rescue changes. So we'll be taking a look at the drowning definition and the drowning chain of survival, which has been developed, and also talk about that team approach. We'll talk a little bit about resuscitation for drowning victims and the use of oxygen and aquatic spinal motion restriction, now bringing it into that environment kind of a thing. So go ahead.
Great. So the drowning definition has changed, and it's a simple, comprehensive, and internationally accepted definition. So this is important. Drowning is the process of experiencing respiratory impairment from submersion or immersion in water. Right. And that can include any of the following outcomes: so death, morbidity, or morbidity. So that's illness. Or no morbidity or no issue at all after it's happened. And so we're really wanting to capture all of those things in a drowning event. Right. So terms wet, dry, active, passive, silent, secondary drowning, none of those are used anymore. They created a lot of confusion. And so we're just drowning is drowning. And we know there's a variety of consequences or potential consequences from drowning.
Yeah. And this new definition is supported by the World Health Organization, and they brought it together really to unify language globally surrounding drowning and drowning management. So it's important that we embrace it, and we may have become used to some of those other terms. I know, secondary drowning is I'm going to dream about it the rest of my life, I think. But we have to get used to the fact that the definition has changed, and for good reason, so that we're all speaking the same language.
Right.
Yeah. So there's the drowning chain of survival as well. This drowning is a major global public health problem, and the drowning chain of survival is a simple, clear tool for Canadians to use to prevent and take action in drowning prevention. So this is a key infographic that I think you need to have part of every course that you teach.
Yeah.
It's really important. It starts to get that message out there that drowning happens all over the place, and the simple steps that should be the consistent steps that we should be taking to look to how to prevent that drowning or prevent drowning injuries overall. So those links are, and we'll go through them a little bit, but quickly they are prevent drowning, recognize distress, provide flotation, remove them from the water, and provide care as needed. So quickly, prevent drowning. So preventing drowning is used by individuals near, on, or around water, and those who supervise or care for others in aquatic settings. That would include lifeguards, but it could also include teachers or daycare workers, right? Mm-hmm. Keep kids within arm's reach when you're near the water. Swim where there are certified national lifeguards, right? Put fences around pools and spas or other aquatic locations. And always wear a life jacket when using watercraft, and complete the swim to survive skills. So that a broad spectrum of preventative actions, some that you would take well in advance of aquatic activities and some that you take while aquatic activities are going on, right?
Yeah.
So that spectrum in prevention.
Really important to focus because drowning is 100% preventable. So we should
Right.
really be focusing on these types of these types of lessons for people. So for recognizing distress, calling for help. So this is recognition and quick activation of EMS that are key elements to this. One of the things that we really want to reinforce with people is that it is difficult to recognize when someone is drowning.
Right.
And we really want to make sure that people understand what a drowning person can look like. Drowning is very quiet. Drowning can be really subtle. And we want to make sure people and it can happen really quickly, less than 10 seconds, and you can have somebody fully submerged.
Right.
So we want to make sure that people have those key messages about recognizing distress, because it's not the thrashing around in the water violently that historically people have been looking for.
Yeah.
And it's really easy to miss it.
Yeah. And one thing I think with this one too is that quick activation of EMS. We're identifying here that at the point that you begin a rescue, and even though you may not have contact with your victim, we want that EMS call right away off the hop.
Yeah.
We can always cancel them later,
Yeah.
but at this point, we're undertaking to put other lives at risk potentially in the course of a rescue.
Yeah.
And we already know there's somebody's life at risk, so let's get the 911 rolling.
Yeah,
kind of thing.
absolutely. And just to put it in perspective, you hitting the water to help person that's drowning, if you call 911, you would not believe the response that it's going to get.
Absolutely.
It is going to be agency that comes out with
Yeah.
boats and so it really just speaks to how serious it is to have somebody in the water in distress. So this is not a one-man show. This needs to be a 911 call, because
Yeah.
they're going to max out the resources for it to protect and preserve life.
Yeah, absolutely. The next would be to provide flotation. So the priority is to interrupt the drowning process by providing flotation. So this is a safe way of intervening if we can, taking that safe approach, and it's born right out of our ladder approach from days of yore, if you will, right? Bystanders drown while attempting to rescue others by not using or a reach or a throwing aid or dropping the buoyant aid and leaving it behind. So, in helping others, we want to try to stay out of the water as best we can to reduce the risk to any rescuers involved. Throw something that floats to the person, and to help yourself, don't panic and stay with any flotation you may have. If we're talking about self-rescue here, signal for help as soon as you can, and if possible, and stay with that float, right? Just float there and wait if that's all you can do, if it's a self-rescue kind of a thing. So.
Yep. Once you have the situation somewhat under control from that regard, the next objective is to get them out of the water, and that's essential to eliminate the risk in the situation. So lots of strategies that can be used, and we really want to reinforce that people are safe about this. So if you can do this without getting into the water to help them, that is optimum. So you can talk them through how to get the aid, how to get to the side, how to get out of the water, and only if safe to do so, you can rescue the person using a flotation aid at the time, but that would be a really high risk action, and we'd like people to look for any other solution to the issue before entering into the water.
Yeah, absolutely. And then the last step in the link is provide care as needed and seek medical attention, right? So basic life support for drowning persons is unique, so keep that in mind. Essentially what we're referring there to is the change in CPR, which is starting CPR with ventilations. Obviously, once that person is removed and we assess the drowning severity, consider the use of oxygen and AED as soon as possible as well. If the patient is breathing, stay with the person until help arrives, and seek medical aid if any symptoms are present, and for all persons who require resuscitation as well, kind of a thing. So that's the drowning chain of survival, and we should be thinking about this whenever we're delivering any life-saving programs. Even if it is a completely dry land first aid program, this should still be part of the teaching materials, because we want to make sure that with every audience that we find ourselves in front of, we are promoting that drowning prevention initiative that is key to the Lifesaving Society.
Yeah.
Yeah.
So the team approach, I think we have talked about this a little bit tonight, so
Yeah.
I don't want to go into too much detail about it, but for, we should be really focusing on national lifeguard teams using choreographed approach to resuscitation. This should be part of the courses. It's key in providing that high quality CPR. And so this is going to be, you can do this in so many ways, and this is why I think this is so exciting. This can be a little bit of group work with discovery process, how it works, how you can tweak it. You can give them ideas for how it works. You can put them in situations where there is one, and then there is two, and then there are three, or
Right.
you can have them all arriving at the same time in a group of 5 and trying to figure out how this works. And the reality is that the more different ways you introduce this into your course and get them thinking outside the box, the better prepared they are going to be for real life when something happens and they need to figure out how to get into team formation to do a better job doing CPR.
Yeah, and that's a great way of spicing up training too, Sarah. Like you were saying, is to change the components or makeup of the team, so that you get that variety. It makes for a lot less boring education when you're teaching and delivering, and it makes for lasting knowledge retention with the candidates, and also a chance to replicate the way things may be. Because one time to the next, hopefully you're not doing CPR twice in 1 week, but one time to the next, things can be very, very different, right?
And I think we need to be prepared for the fact that, what the way people practice in class is probably, if they ever do have to do it, it's going to be a totally different circumstance. And if we've drilled to them into their programs, you stand here, you switch here, this person come in here, then they're going to wind up smack in the middle of a situation that totally is not what they've practiced for. And they're going to lack the ability to adapt because they didn't have to learn how to do that. So it's important to teach them there's so many ways to do a team approach, and let's just start getting creative. And how do we take these objectives of high quality resuscitation and play them out in 10 different ways in all these different circumstances?
Yeah, and it also allows for an opportunity for incorporating judgment assessment in teaching as well, and that's really important. It's a reason why it's a fundamental of our life savings education programs is judgment, because it's so important in applying during critical incidents and rescue situations is good, solid judgment skills. Resuscitation of drowning victims, like we had mentioned earlier, the evidence continues to support an airway breathing circulation approach. Rescuers should start with 2 breaths, then begin compressions. I know my national lifeguard instructor told me to get the patients all the way out of the pool first, but
that's beginner stuff. Come on. So use of oxygen. So again, oxygen is beneficial if people have hypoxia or not enough oxygen in their blood. And it is recommended to be used if somebody has had a drowning event. Decompression sickness, which again is not going to be happening
very often, but
it can. Carbon monoxide poisoning, and obviously there's some other situations where it may apply as well, but those are some of them. And what we want to give oxygen if somebody's blood oxygen level or saturation is less than 94% as measured by a device.
Yeah. So, and we'll talk a little bit more about pulse oximeters, but I think it's interesting to note that this is a technology that when I started in EMS was, on the cutting edge of just making it into the pre-hospital environment. And here we are many, many moons later, and we're driving that closer to the point of patient care. And now we're talking about lifeguards accessing pulse oximetry kind of thing. The other thing before we jump off the slide, Sarah, I wanted to point out was we talked about the recommended providing oxygen for those 3 conditions: drowning, decompression sickness, and carbon monoxide poisoning. Oxygen for those 3 types. Yes, there are other injuries. Heart attack or myocardial infarction comes to mind as one where oxygen can be beneficial, but it's not a recommendation for the blanket application of oxygen in other situations other than these three.
Always.
Yeah, all these three, exactly. And of course, evaluate your patients. And if they have a need for oxygen with other medical conditions, then provide it. And that's really where the pulse oximeter comes into play.
Speaking of which.
Yeah. So a pulse oximeter can be used on wet victims. So it's a very passive, non-invasive technology, pulse oximeters. And we have to remember that it's not always reliable on hypothermic victims. That's one type of patient that's not very reliable. I know patients that have extensive bleeding. It can be another example.
Patients that are moving.
Patients that are moving, good point,
Yeah.
So never rely on the monitor itself, but it is something that we can incorporate into training programs. It's easy to be used and easy to incorporate into training programs. The way I always say it is pulse oximetry is like adding a second pulse as far as how complicated it is to assess. It's even less. You snap it on somebody's finger and there are your two numbers. There's your pulse and there's your oxygen saturation number, and it's that simple. Plus or minus 94%.
And it's more accurate than the heart rate
that's
that we're
right.
probably taking.
Yeah, that's right. Than a physical heart rate.
Nobody's good at doing math during an emergency, and that is true of like first aid folks all the way up to physicians. Nobody's good at math.
Sure.
In the heat of the moment.
I feel obligated to say a pulse oximeter doesn't evaluate the quality of a pulse.
That's true.
So there's still reasons to put hands on evaluating a pulse.
Yep.
But a pulse oximeter is another tool that we can now use to help us in that evaluation.
I agree 100%. Okay, so aquatic spinal motion restriction. So if there's a suspected spinal injury in the water and they require CPR, they need to be removed from the water. So again, this is going to be the chest, head, and out. And I cannot reinforce this enough. You must get this person out of the water, and I think it's reasonable to put them on the board and get their chest and their head figured out, but this person's their mortality increases with every second that passes that they don't have CPR implemented. So we really need to be focusing with our candidates that the priority is CPR, and we just need to figure out how to get them on the water while maintaining reasonable care for a suspected spinal injury.
The goal is now to use the resuscitation or the CPR board, pardon me, the spinal board as an extrication tool when we have a non-breathing. So just strap them real quick and get them out of there. If you can't get the head done up, that's fine. The priority is to use the board to get them out of the water to begin resuscitation. If they're breathing, then we can go through the longer longer steps or the processes we're more familiar with, kind of a thing. And we've already talked about the application of jaw thrust here.
One and done.
One and done, right? So just so we're clear. You betcha. So we've basically come to the end of our evening presentation here on information. So what we'll do is I'll just go through this slide and then we have a quick demonstration. So just a reminder that to complete the update process, you must do the following. You have to answer the accompanying assignment in this video is found in the toolkit. If you do not have a toolkit account, go to lifesaving.mb.ca/toolkit to sign up. You'll need your Lifesaving member ID. That can be coordinated through the branch office Monday to Thursday 8:30 to 4:30 and Friday 8:30 to 12:30. And there's a recertification fee that will be in the toolkit that you'll be able to process via credit card right there. The certification fee is $20. The fee will go up to $30 as of January 1st. So
get your money in.
Get moving, right? And then purchase through the office the revised Canadian First Aid Manual and First Aid Award Guide. Now, as I mentioned, both of those are not in the office yet, but we're hoping by the end of the week that we'll have both of those into the office. So call in and you can make arrangements to get that information, or get those books, I should say. Once you have completed these steps, you will input the 2016 First Aid update into your profile and finish the processing any instructor certifications of yours that have been placed on hold. Certification cards are not going to be issued for this, but proof of completion is mandatory upon and can be obtained from so or better on the quiz, and it's covering the information on the content that we've gone through tonight, kind of a thing. So I think without further ado, we're going to move on to our last demonstration here before we move on to Twitter questions. And we've got Ashley and Megan who are going to take us through two-person use of a BVM.
Okay, so we're going to apply it just like a regular mask, C and E, and I'm going to make sure there's a nice tight seal on it, and then Ashley's able to give breaths with her too. Still ensuring that the head's tilted back nicely and that air is going into the lungs. Okay, thanks guys. Now just give us a second as we switch our camera around.
Hello again, and as Kevin said just before our last demonstration, we are pretty much at the close of the presentation. We have been watching Twitter, and I know that we've had quite a few questions come in. So Kevin and Sarah are going to pull those over, and Kathy and myself will be answering those, and if we have to, we can also pull in some demonstrations if required. So I'm just going to check in, because I can't see the screen right now, for the first one that we're going to answer. Okay, sorry, they're still checking the screen. So give us just a second.
Okay, so we're good here. So let's take a look at some of the questions that we have here. Students are always asking, will giving sugar harm if the sugar is high? So what is the science behind giving sugar anyway, even if they may have high sugars?
Yeah, so I mean, that is a very common question, comes up all the time. Right now, as you'll see in all the society resources as they are released, if you have a diabetic patient, give sugar. If you're unsure of what they need, give sugar. The amount of sugar that you're going to give them compared to probably what's causing their problem is going to be minuscule. And the fact of the matter is, if they don't get better in approximately the 5 to 10 minutes, as indicated previously in our show, then you're going to have the indication, oh, they didn't get better, I need to activate EMS, they need to go to hospital for additional care.
Okay, great. So now we have another one here about, where did it go? Allergic. Well, let's look at this one here, sorry. The escalating cost of epinephrine should not affect treatment or what is taught to candidates. That's a statement that's being made, but sorry, I thought it was a question. Anything you want to add to that?
Totally agree. We teach what is the appropriate treatment protocol for somebody that's having an anaphylactic reaction, and that's what our mission is to teach people what to do should they be having to help somebody with that kind of an emergency.
And I think Kevin made a side mention there to Allerject. I know I saw one of the tweets earlier when we were off camera. Yeah, right now, just so you're aware, all of our teaching materials show and say that you should be using the patient's auto-injector to assist them. Currently in Canada, there is only one brand of auto-injector on sale, which is the EpiPen. There are other brands that have been out there in the past and may be back in the market in the future. Don't worry about the brand. If they have the medication, you should be getting them to use their auto-injector and assist them as required.
Okay, so we have another question here for you, and that is that it says, I love no soap. I'm always concerned about scented products and allergies. Was that the motivation behind the minor wound injuries
That
management?
was part of it. They did a lot of research, as I know you were told in the presentation, and actually discovered that soap itself can be toxic and damaging to skin cells. So that was the main reason for saying, you know, let's not use soap, let's just use water, which everybody has, and running water is far more effective at cleaning a wound than soap is.
Okay, great. So I think we've looked over all of our Twitter feed, and that seems to be it, aside from a few praises that we got from people. And thank you very much, everybody, for all that wonderful praise. We had as much fun doing this as I hope you had enjoying tonight's event. And with that, I think we will bid you adieu. Thanks again, everyone.